Good morning. We're going to talk about dialysis catheters, a little lighter topic this morning. So, the jugular vein, as you know, sits deep to the sternocleidomastoid muscle for the majority of its extent. And so, easiest access to the jugular vein is between the two heads of the muscle as they insert on the clavicle. Turning the head in the direction opposite to the side that you're accessing is generally will open up that window and allow you more direct access to the vein. So ultrasound should be the standard way to access a vein. Prior to routine access with ultrasound, we would access the jugular vein blindly using our landmarks, right? So the apex of this triangle that is created by the bellies of the heads of the muscle, you would access that. You would head always towards the ipsilateral nipple. This allows you to avoid the carotid artery. So when you look at it under ultrasound, you'll see that little maneuver of heading towards the ipsilateral nipple really allows you not to access the carotid artery inadvertently. So because the artery sits deep to it just at that level. And so with the needle at 45-degree angle, ipsilateral nipple, this is the best location to access your jugular vein. So the anatomy is very variable for the veins, but there are certain things that are quite predictable. So the right IJ vein is the choice generally because you have a straight shot. So if you look here at the anatomy, it's fairly straight. You have your IJ that joins your brachiocephalic into your SVC. And the left side has a little bit more curve to it. So you have two turns that may become significant, and this is the reason why we don't choose the left IJ first. This is something that can be easily dealt with by placing a stiffer wire in order to allow for a catheter to go in easily. But this is the reason why we always choose the right IJ if we can. Again, this is another depiction of that left IJ coming in, as you can see, a number of turns. So this is a depiction of an SVC stenosis. This is a complication of chronic catheter use. You can see here the filling defect in the SVC, the stenosis. And when this happens, collaterals, of course, will develop in order to allow for venous drainage. So who can tell me what this large vein that is in arrows? This is a large collateral. This is the azygos, correct. So the azygos vein becomes one of the largest and most important collaterals, particularly for the right side of the thoracoabdominal region and the chest. So the right side is usually collateralized by the azygos vein, although it participates in the drainage of all of the venous drainage of the body. So this is something where you can see that this would be easily mistaken for an SVC. So you have to be aware of your anatomy in order to understand what it is you're looking for. So here's a depiction of the azygos venous system. And you can see here what I'll point out. What's most important is this, the accessory hemiazygos vein, the hemiazygos vein, and this is draining the lower portion of the thorax. This is draining the upper portion. And then they join and they form the azygos vein. So keeping that anatomy in mind helps you to figure out where your catheter is going if it should try to go into an abnormal place. So what percent of patients should be maintained on chronic catheter use? According to the guidelines, less than 10%. So less than 10% should have chronic catheters. That is, a catheter that is in place without a maturing fistula. Of course, if you have you're in the process of maturing a fistula, a catheter is appropriate. But less than 10% of your dialysis patients should be maintained with chronic catheter use. And this is a busy slide. You don't have to read it. It comes out of the guidelines. The bottom line is a tunnel catheter is essentially appropriate in most situations. Yes, you can put in a temporary catheter if you're dealing with an acute need for dialysis, but even in those settings, a tunnel catheter is appropriate. Fact, there are 30,000 deaths every year due to improper catheter placement, which results in vein injury and exsanguination. This is actually not true. My husband thought this would be funny and wake you up at this time in the morning. So this is an important little point to make. A temporary catheter looks like this, and a tunnel catheter looks like that. So many medical students will describe a patient. They will say that this patient has a subclavian tunnel catheter, just simply because the exit point is outside the anterior wall of the chest. And all you have to do is palpate that catheter and its course, and you can see that they both enter the IJ vein. So this is a mistake not to be made by a vascular surgeon. Okay. So there is generally no difference in the various designs of tunnel catheters. They are essentially all equivalent. But basically, the bottom line is, given enough time, if you have a central venous catheter in place, it's going to cause central venous occlusion. And this is the most feared and worst complication. This is what it'll look like. You can see here absence of urnominate and SVC and extensive collaterals. So it's very important when you talk to your patients, we are ethically responsible as vascular surgeons to tell them that this is a temporary bridge to a permanent access. Their permanent access can be a graft, it can be a fistula, but always talk to them about their transplant option and whether or not somebody, their nephrologist, has talked to them about transplant, because that would be their ideal outcome, is to be transplanted, of course. And so again, the preferred site is the right IJ vein. The least preferred is the femoral, mostly because of the infection risk. Again, 45 degree, you use your ultrasound for insertion. You can actually use your needle without a syringe because these dialysis patients generally have enough central venous pressure where you don't actually have to aspirate as you're accessing the vein. Placing your guide wire in the IVC is very important. It gives you a lot of support, right? So if you can't get it down into the IVC, you should make every effort to use a different catheter to steer your way down, because this is probably the most important part of doing a left-sided IJ access. So again, if you have a hard time, you just think of it as a regular venous case. You put in a sheath, a steerable catheter, and place that wire down in the IVC. And then continue on with your easy tunneled catheter placement. So this point, this keeping wire loose, you don't actually want to keep the wire loose, but if you think about it, you're probably already doing this already. There's a push and pull that goes on with advancing your dilators and your catheter. And so as you're doing this, you have to be cognizant of this push and pull, because the force, the direction you're pushing in is not the direction you want the catheter to go in. And so it's very easy, you can imagine, from a left-sided access to end up with your catheter in the aorta. But if you're simply keeping that wire and just doing this push and pull, as you can imagine, I'm sure you're already doing, this is an important tip. The tip of the catheter should be placed at the right tracheobronchial border. This is a rough approximation, but really just at the right atrial junction to the SVC. So again, watch for the azygous vein. In here, this is again another picture of retrograde flow down that azygous vein. This catheter, the tip is in the azygous vein. So this wouldn't be an acceptable, even if you got return on your catheter, this is not ideal. Even though the azygous can get very large, the flow generally won't be high enough in order to sustain catheter, and you're probably going to find that the catheter is not going to last very long. What's up with this one? Can anybody tell me where this catheter is? What vein? So that's that accessory hemiazygous on that side. So again, not an ideal placement for leaving a catheter in at that point. How about this? Would this be okay to leave the catheter in like this? Yes, it would, right. So this one went through the accessory hemiazygous, back up through the azygous, and the tip is actually in the SVC. So that's just something to keep in mind. Femoral catheters that need to be long enough to reach the straight portion of the IVC. You can see here that this catheter here, coming from the patient's left side, it would be sitting against the wall of the vena cava, and so it's not ideal. You really want something that's going to stay in the straight portion to minimize any kind of fibrin sheath development. Tunnel laterally, not inferiorly, even though this picture here does look bad. In order to really try to determine whether or not this would be acceptable or not, you'd have to get an oblique picture, and it may be okay. But you're less likely to have a kink in your catheter if you tunnel laterally and if you come real close to the clavicle when you first access that vein. So for catheter exchange, we generally use 2 stiff angle glide wires. Generally, it's better to do this if the catheter has been in for 2 weeks because you have a well-developed tunnel. The tips of the wires are in the IVC when you do that exchange. So complications. This is one very common complication that you'll see. You have a catheter. The dialysis unit tells you it's not working, so you change it out. It seems to be fine, and then 2 weeks later, you're getting a call saying that this is not working again. And if you shoot contrast through your catheter, you'll find something that looks like this. And this is a fibrin sheath that develops over your catheter. This, if you keep putting your catheter back into this tiny little channel, you're going to have the same problem. If you access this vein from a femoral vein approach, you would not get into this channel. It would be actually very hard to get into that channel. So you could come up from that direction and you would avoid this. But really the way to treat this is to actually do balloon angioplasty. You balloon that fibrin sheath. You have to use a very high pressure balloon, go up to very high pressures with it, and you're essentially just bursting that fibrin sheath and allowing for that vein. And you can see the outcome there on the bottom. You can get a nice lumen once again, and then the catheter site can still be used. Here, this is pacemaker leads. Pacemaker leads are often associated with central vein stenosis because they're sitting against the vein and causing that stenosis. You can balloon angioplasty around those pacemaker leads, as you have here in this picture, and it'll give you some temporary benefit. The truth of it is, though, it's just going to keep coming back. So it's best not to create a dialysis access on the side of a pacemaker. The treatment of catheter infection is fairly straightforward. You're pretty much always going to remove the catheter. The question is, if you have an exit site infection, you may get away with just treating with antibiotics or local antiseptic measures. But if you have bacteremic infection, the catheter has to be removed. You replace the catheter at some point in the near future. Tunnel infection, you can actually get away with removing the catheter and simply passing your wires through it and bringing it out through a different tunnel site. So this is a little bit of a complex procedure, but if you've participated in this kind of thing, you know what I'm talking about. So, of course, surgeons who place more than 50 of these a year are going to have the least complication rate, and that ended faster than I thought. But that's good. That's enough on dialysis catheters. Thank you. Yes. Well, it's just a very tiny channel. The catheter won't work because you're sitting in this tiny, very, very small lumen. You know what I'm saying? And if you keep exchanging it right over that wire in that same lumen, you're going to continue to have a catheter in a very, very small vein, essentially. It creates a new vein. So by splitting that fibrin sheath, you're going to be back into your SVC again. Does that make sense?